Great. Thank you so much. And thank you everyone for joining us today for the National Alzheimer's and Dementia Resource Center webinar, Grant to Growth, Building Sustainable Dementia Services, Supports, and Training. The National Alzheimer's and Dementia Resource Center webinar series is supported by the Administration for Community Living. Before we start, Chris Stockton of the Administration for Community Living will provide a brief welcome. Chris?
Good morning / afternoon to all of you. Thank you for taking time out of your busy days to, wow, sorry, my screen changed and just threw me off. For taking time out of your busy days to join us on this very important topic. And thank you, Jill and Melissa, for sharing your wealth of information and knowledge you have on this topic. Sari, if you'd like to take it from there.
Sure, thank you so much. So as you heard from Chris, today's presenters are Melissa Hunter and Jill Sigliana. Melissa Hunter is a technical assistance provider and researcher at RTI International, where she works on the National Alzheimer's and Dementia Resource Center project. She has a background in social work and economics and previously held roles at her local Department on Aging and at an adult day health program, where she developed and delivered community-based programs for older adults and caregivers. We also have with us today Jill Sigliana, who is the Executive Director of Memory Care Home Solutions, a nonprofit organization dedicated to improving quality of life for people living with dementia and their families. With expertise in occupational therapy and health system innovation, she has led statewide and national efforts to integrate evidence-based dementia care into clinical and community practice. At this time, I'll turn the presentation over to Melissa Hunter to begin. Melissa?
Thanks so much, Sari. Hi, everyone. My name is Melissa. I'm excited to be here on behalf of the Resource Center to give a sneak peek of the results of a survey we conducted with a sample of past grantees and the report that we wrote based on those results. Next slide. So just a quick run through of what you're going to get from this portion of the presentation. This really is an overview of the forthcoming sustainability report. And we also hope you'll walk away with a better understanding of the history and purpose of ACL's dementia grants, learn more about how grantees have sustained their grant activities, as well as why they choose to discontinue some activities, and then hear 3 brief case studies from grantees who have successfully sustained impactful grant activities. So I'll start with an overview of ACL's dementia grant programs. ACL's dementia grants have been in place since 1992 and have evolved over time to meet the changing and growing needs of people living with dementia, caregivers, and professionals. The ACL Dementia Grant Program began as the Alzheimer's Disease Demonstration Grants to States and changed to the Alzheimer's Disease Supportive Services Program, or ADSSP, in 2008. In 2014, the Alzheimer's Disease Initiative Specialized Supportive Services, or ADISSS program, was created to target gap areas identified in the national plan to address Alzheimer's disease. These gap areas included services for people living alone with dementia, services for people aging with IDD and dementia, and behavioral symptom management training and expert consultation for caregivers. The Alzheimer's Disease Programs Initiative, or ADPI, was formed in 2018 by merging ACL's state and community dementia programs, ADSSP and ADISSS. Next slide. These grants go to states, communities, and tribal organizations to improve and expand the delivery of dementia-capable home and community-based services. They fund demonstration projects and allow the grantees to develop and pilot dementia programs that fill gaps in services within their communities. Grantees must use funds to provide new services or expand existing services to new areas or populations. They provide an opportunity for grantees to try services and supports they otherwise may have been unable to implement for a variety of reasons. Next slide. They also help organizations learn how to successfully tailor programs to their community's needs. Grantees have reported that their projects positively impact people living with dementia and caregivers. They've developed trainings and products for local and national use, translated tools and care models to fit their own communities and populations, and embedded dementia-capable systems into their organizations. All grantees are required to provide programming that improves quality of life for people living with dementia, but some other common outcomes include reduced caregiver burden, improved caregiver self-efficacy, and increased social connection for both people living with dementia and caregivers. Many grantees also offer training and education to communities and professionals through their grants. The goals of dementia trainings vary, but may include improved knowledge related to the basics of dementia, enhanced care for people living with dementia, and increased awareness of the signs and symptoms of dementia. So now that you have some background on the history and intent of ACL's dementia grants, I'm going to provide some more detail on our report, beginning with the purpose and methods. So we know that the ACL dementia grants are intended to support the sustainability of successful efforts beyond the federal funding period. So for this report, we wanted to better understand exactly what activities grantees had sustained and how, as well as what the most common reasons for not sustaining an activity might be. Next slide. To do this, we surveyed a sample of grantees that were funded between 2014 and 2020 and had ended by December 31st, 2023, meaning they had been operating without ACL grant funds for at least a year as of the survey. Our sample totaled 69 grantees representing 83 grant projects because some grantees had more than one grant during that time period. And we had an 84% response rate, so 58 grantees responded, representing 72 grant projects. Our staff reviewed the work plans, evaluation plans, and final reports for these grants to identify their main grant activities and created grantee-specific surveys that asked a series of questions about each activity. Survey questions were related to whether they sustained the activity and how, and why they discontinued activities. After surveys were completed, 9 grantees with varied activities and methods of sustaining were chosen for interviews and case studies. And you can see on the graph to the right here, just kind of the different types of organizations that were represented in our sample of grantees. Next slide. So I'll go into the findings now. You can move to the next slide. We know that whether a grantee continues to sustain an activity can change over time as their community and organizational needs and priorities change. And because of this, grantees were first asked if they had sustained each activity for any period of time after their grant funding ended. If yes, they were then asked if they were still offering the activity at the time of the survey. Almost all grantees reported sustaining some or all of their grant activities for some period of time after their funding ended. Grantees reported sustaining a total of 295 activities after the end of their grants. 13 grantees reported they sustained all of their activities, and 44 reported they sustained some of their activities. Of the activities sustained for any length of time after their grant period ended, 85% were still being offered at the time of the survey. The graph here to the right shows the 8 most common categories of activities, so the ones that grantees implement most often, and the percentage of those activities that were being sustained as of the survey. So you can see 81% of care consultation or case management programs were still being sustained, followed by 79% of outreach, 74% of education or training activities, 73% of cognitive screenings, 67% for support groups, 65% for respite, 60% for adult day, and 40% for arts and arts engagement programming. Next slide. So if a grantee indicated that they had sustained an activity, they were also asked about if and how they had changed it after their funding ended. Once federal funding has ended, grantees sometimes change the way they deliver activities, whether by expanding, adapting, or reducing the service in some way. This graph shows the percentage of grantees in blue that indicated they had expanded, adapted, or reduced at least one of their activities since the end of their grant, as well as those that had made no changes. It also provides that information at the activity level, showing in green the percentage of all currently sustained activities that were expanded, adapted, reduced, or had no change since the end of the grant. I also want to note that the graphs are laid out in this way in future slides as well, with the blue bars showing the data at a grantee level and the green bars at an activity level. Because respondents could choose more than one response option, the totals may add up to more than 100%. For example, an activity could be adapted because it's now offered virtually when it was originally offered in person, and it could be expanded because it's being offered more frequently. 70% of grantees reported they had expanded one or more of their sustained activities since the end of their grant funding. Examples of expansion include delivering activities in a new geographic area or to new audiences, translating materials to new languages, or increasing the number of staff who deliver the activity. About 60% of grantees reported adapting some of their activities. For example, they could have transitioned an activity to a virtual or hybrid model rather than providing services in person, or changed some of their educational curriculum. Over half of the grantees indicated they had not made any changes to the way they are carrying out their activities, and only 28% of grantees indicated that they had reduced any of their sustained activities since the end of their funding period. This may mean they're offering the activity at fewer locations or reduce the number of sessions they're providing. At the activity level, it's worth noting that all of the activities that were still being sustained as of the survey, only 14% had been reduced since their grant funding ended. The remainder of the activities had been expanded, adapted, or were being offered in the same way as before. Next slide. We also asked grantees to tell us what methods they had used to sustain activities after their grant ended. 4 funding sources were used by nearly half of all grantees to sustain their activities. Unsurprisingly, these were also the most common funding sources at the activity level. So many grantees noted they had used their organization's existing budget to sustain activities. Because these grants are used to launch new programs, once the activities are up and running and deemed successful, grantees are often able to work with their leadership to earmark funds within the operating budget to sustain the work. 3 other funding sources were also used by nearly half of the grantees to sustain one or more activities, and those are state funding, philanthropy, and Older Americans Act funding. You can go to the next slide. Nearly 1/3 of grantees reported that they relied on in-kind support from partner organizations to help sustain one or more of their activities. Examples of this type of support could be using partner organization staff or space to deliver the program, or working with partner organizations to reach specific communities where they have stronger connections or expertise. For example, we see this a lot for organizations that serve people living with IDD. They might take on that activity moving forward after a grant ends. Just over 1/4 of grantees recorded their in-person trainings or produced materials for self-guided use, which presumably reduced the cost of delivering the program. And 23% of grantees ensured the sustainment of activities by embedding support for the activities into organizational policies. For example, making dementia training a required part of staff onboarding. Next slide. So sustaining grant activities after the original funding ends can be challenging for grantees, and in some cases, grantees cannot or choose not to sustain some grant activities. For activities that were no longer being offered or were never sustained, we asked grantees why they decided to stop sustaining them. The reported reasons included limited resources, shifts in organizational priorities, limited participation in the activity, cost effectiveness considerations, and limited impact of the activity. The most commonly reported reason for discontinuing an activity was limited resources, which was reported by 89% of grantees in relation to at least one activity. Some grantees also reported, however, that they were continuing to pursue other funding sources and hope to resume those activities in the future. Next slide. So now we'll go through 3 very brief case studies before I turn things over to Jill to go more in depth into her own organization's sustainability story. We'll start with Amazing Place, which is a faith-based nonprofit in Houston, Texas. They designed the Faith Care Connections program to identify and support people living alone with dementia or at risk of dementia. Through this program, they partner closely with churches and their pastoral care teams and aim to make churches more dementia-friendly through training and support. Amazing Place adopted the Benjamin Rose Institute Care Consultation Program, or BRICC, to include home visits with a trusted church member present. Churches provide the initial contact and follow-up, ensuring that the program is a partnership rather than a replacement for church-led care. Although the program does not serve a large number of individuals, the depth of impact and the church's appreciation underscores the program's value. One church even provided a special 3-year grant to Amazing Place to continue the program, demonstrating strong community support. Costs remain relatively affordable with just 3 part-time staff members and the annual costs of the BRICC license. Churches contribute in-kind support through their staff and church-led care. The Faith Care Connections program has also adjusted the intensity of the care consultation to be more informal, which allows the program to remain sustainable and avoids overburdening church partners. Next slide. The Latino Alzheimer's and Memory Disorders Alliance, or LAMDA, in Chicago, Illinois, created a community health worker program to improve quality of life for people living with dementia by equipping community health workers, known in Spanish as promotores, with culturally and linguistically appropriate education about dementia. These community health workers are embedded in communities and use their local knowledge to deliver relevant information and support. The decision to sustain the program was driven by its proven effectiveness in reaching Latino populations, which is important because this group of individuals is at a higher risk of developing dementia. The community health workers are able to build trust in these communities, which helps the people living with dementia and caregivers they're working with feel more comfortable receiving services that they may not otherwise choose to access. The program built strong partnerships with local churches, community organizations, and businesses. Empowering community health workers to draw on their existing relationships and community ties really enhanced its impact. And adapting educational tools to fit the audience increased engagement and ensured the information was meaningful and accessible. LAMDA's been able to sustain this program through ongoing local partnerships and by keeping the program closely aligned with the community's evolving needs. Next slide. Nevada Senior Services is a nonprofit organization located in Las Vegas, Nevada. They created the Hospital to Home Care Transition Program to help people living with dementia get out of a hospital setting and return successfully to their homes. Nevada Senior Services noted the importance of finding and reporting on the one thing that makes a program worth investing in for stakeholders. For Hospital to Home, that one thing is hospital readmission rates. Fewer than 1% of hospital to home participants have been readmitted to the hospital for the same diagnosis within 30 days, which is significantly lower than the Medicare readmission rate for Southern Nevada. Hospital funders appreciate hospital to home because it not only shortens the length of stay, but also helps them avoid readmission penalties. The hospital to home model has expanded over time from focusing only on people living with dementia in a hospital setting to taking on people with different types of diagnoses and from different referral sources. They currently enroll about 300 new cases each month. Nevada Senior Services used a cost analysis to determine the true cost of implementing hospital to home. They were able to build out the cost for a typical case and develop a unit rate, including overhead. Knowing the true cost of implementation allows Nevada Senior Services to tailor the program and how much they charge for it depending on the type of payer and the services they're looking for. Hospital to home is sustained using city and county funding, Older Americans Act funds, and fee-for-service. Their contract with the county is their single biggest contract, while OAA funds fill in service gaps. Nevada Senior Services also contracts with for-profit organizations to provide services. These kinds of contracts, while not specific to hospital to home, allow the organization to invest in staff, training, and improving systems. Part of the success comes from being comfortable with asking to be paid for services and looking for non-traditional payer sources or partners. Next slide. So I'd like to just wrap up with a few of these points. So our survey results found that ACL's dementia grants have a lasting impact on people living with dementia, caregivers, and communities even after the funding ends. Almost all grantees surveyed sustained some or all of their grant-funded activities, and a majority of those activities were still being offered as of the time of the survey. A vast majority of sustained activities were expanded to serve more people or adapted to meet different needs. Grantees used this funding to test new programs, determine which activities have the most impact, and tailor dementia offerings to meet the needs of their communities. And grantees have been able to leverage multiple sources of funding and support to continue their dementia activities and further impact people living with dementia and caregivers in a positive way. Next slide. And just want to kind of wrap things up with this great example of how grantees can use this funding to develop a program to meet existing needs and use the data that they gather during their grant period to secure long-term funding and support. So this testimonial came from a state grantee during our survey, and they said that findings from those grants convinced the legislator at the time to authorize a respite program for caregivers of individuals with ADRD. It would not have been possible without the 2 AOA, now ACL grants that were piloted, first in 8 and then in 14 counties, that showed the need for respite and the huge gap in services. Next slide. So that's it for me. Thanks so much. And I will now hand it over to Jill.
Thank you, Melissa. I'm Jill Sigliana, Executive Director of Memory Care Home Solutions, and today I'll be sharing how we've sustained dementia training and the evidence-based intervention COPE after ACL grant funding ended. My hope is that you'll walk away with practical strategies that you can adapt in your own communities. Next slide. Before we begin, I'd like to acknowledge the 2 ACL grants that made this work possible. Next slide. Our objectives today are twofold. First, we'll discuss strategies for sustaining dementia training and interventions like COPE beyond the time-limited funding. And second, we'll look at practical ways to leverage cross-sector partnerships and philanthropic support to embed dementia best practices into lasting systems of care. Next slide. So Memory Care Home Solutions, as Sari mentioned, is a nonprofit organization in St. Louis serving a bi-state area of central Illinois and Missouri. Founded by a family caregiver in 2002, our mission is to improve dignity and quality of life for people living with dementia and their families. We achieve this mission by delivering evidence-based programs that meet the needs of our community, which is exactly why ACL funding has been a great fit for our organization. Through outreach and education, we also aim to improve the overall standard of care for home and community-based dementia treatment. Next slide. We offer 3 family-centered lines of direct service, and those are the first 3 numbers on this slide. In dementia navigation, each family is paired with a navigator for assessment and monthly meetings to learn how to manage the progression of dementia at home for as long as possible. In this presentation, I'm going to focus more on our 2 clinical service lines, occupational therapy and individual counseling, which both emerged as a result of our translation of COPE. So in addition to community education, we offer opportunities throughout the year for healthcare professionals of many disciplines and backgrounds to earn continuing education credit through workshops and courses on best practices in dementia care. All of our service lines, whether that's direct service or education, share common goals to improve the health and well-being of people living with dementia and care partners, and to keep families together in the community. As an organization, we are committed to making our programs affordable and accessible to families. And we believe that non-pharmacological treatments for dementia, like for other chronic health conditions, should be covered under health insurance benefits when possible, which explains why we pursued Medicare Part B reimbursement as part of our sustainability plan. Next slide. This chart demonstrates how families flow through our services today, which is 4 years after the ACL funding concluded. So each family starts in dementia navigation, where a majority of families actually have their needs met through individualized education and consultation over the course of a year or longer. So many people never progress out of this big green circle, but some people need more intensive clinical intervention. For families who are supporting someone in the moderate stage of dementia and who wish to work on the functional challenges or the behavioral symptoms of dementia, they are offered in-home occupational therapy based on the COPE model I'm describing today. For care partners who need additional mental health support so that they can improve their ability to care for the person with dementia, we offer short-term solution-focused psychotherapy delivered by our licensed clinical social workers. These two services are covered through outpatient Medicare Part B health insurance benefits. Next slide. So how did we get there? Well, we applied for our first ADPI grant in 2017. For our project, we selected COPE, developed by Laura Gitlin and Catherine Pearsall, as our evidence-based program. And COPE stands for Care of Persons with Dementia in Their Environments. It features 10 to 12 in-home occupational therapy visits designed to optimize the functional independence and activity engagement for the person living with dementia, while also improving care partner dementia management skills and self-care. Our translation of COPE featured an enhanced role for social workers to support the mental health needs of care partners and provide assistance navigating community resources. In addition to the direct service, we established a dementia care network to serve as an advisory and network building committee dedicated to dementia care services in the region. We created a number of educational events for professionals and paraprofessionals to fill gaps in knowledge and skills related to caring for and providing services to this population. Next slide. This project proved transformational for our organization. 246 families completed the COPE intervention and experienced benefits that lasted beyond the time they were in COPE. Our dementia care network grew from 5 organizations to 10, and we trained more than 1,500 professionals in dementia best practices. But beyond this tremendous community impact, the 3+ years of time and funding allowed us to build significant infrastructure to sustain these activities beyond the grant period. So I encourage grantees to look at these opportunities not only as program building opportunities, but as capacity building projects to invest in the systems needed to operationalize and scale your work. Next slide. To evaluate the impact of COPE, we examined a number of adverse health events among persons living with dementia. Regarding falls, which is one of the more common adverse events, the proportion of people who experienced a fall significantly decreased from their baseline to when they were discharged from our OT COPE program, and that was maintained for 3 months after discharge. Similarly, the proportion who had a hospital admission also decreased from baseline and was maintained at 3 months post-COPE discharge. So these findings indicate improved quality of life and reduced healthcare costs, which families, health systems, and payers all care about. Next slide. Turning our attention to outcomes among family care partners, care partner readiness to implement dementia care strategies allows Memory Care Home Solutions to target caregiver education to the caregiver's current stage of acceptance and understanding. And because caregiving is complex, requiring emotional, physical, and practical adjustments, readiness is not a single yes or no state. Instead, it develops in stages consistent with the trans-theoretical model of behavior change. So this scale reflects the care partner's understanding of symptoms and their willingness to try different strategies in the management of those symptoms and behaviors. So using this lens, professionals can provide stage-matched support that meets caregivers where they are, instead of overwhelming them with tools that they aren't ready to use yet. So caregiver readiness improved, indicating they were better able to manage challenges with greater confidence. Next slide. We measured caregiver well-being through the Perceived Change Index. Caregivers reported significant improvements in well-being from baseline to discharge. Those scores dipped a little bit after services ended. So for us, this highlights both the effectiveness of COPE and the need for ongoing support to sustain gains. Next slide. The challenge, of course, is sustainability. Excellent programs often fizzle out after a few years of funding. So the key questions we faced were, how do we keep training others in best practices on dementia? And how do we keep COPE alive beyond the grant? And just talking about a 3-year project in a 20-minute webinar makes it sound easy, but in reality, the project period included many failures and lessons learned the hard way, but all of that prepared us for sustainability after the grant. Next slide. We identified several keys to sustainability, which were building strong partnerships, leveraging Medicare Part B billing, developing fee-based training models, and cultivating philanthropic and community support. And each of these pillars plays a vital role to this day in our sustained program delivery. Next slide. So partners with like-minded goals and missions have been central to our success. Because we were able to prove impact and outcomes during the grant period, partners felt confident extending paid contracting opportunities to memory care home solutions. The Geriatric Workforce Enhancement Program is another federal funding mechanism. So we subcontracted with our local GWEP grantee, St. Louis University, and have been able to continue training healthcare students and professionals. The state of Missouri's Department of Health and Senior Services is also a recipient of a BOLD grant. Through partnership on this grant, we've contributed to state-level dementia infrastructure and policy and been compensated for delivering dementia education to lay audiences and professionals across our state. My advice to any organization seeking to sustain their ACL-funded programs is to explore how your services align with your state's and national priorities. So by identifying where our work intersects with objectives in the Missouri Alzheimer's State Plan and the National Alzheimer's Project Act, we've become an essential partner in a much broader system. Next slide. Moving from a purely charitable model, which is where we were before this grant started, to Medicare Part B billing was certainly the heaviest lift of the grant period. We began to prepare the organization to bill Medicare during the project planning phase, and we used the entire 3 years to enroll and credential our organization and clinicians in Medicare, Medicare Advantage, and other commercial insurance plans. Then we tested various billing codes to cover our COPE occupational therapy visits and social work counseling sessions as psychotherapy. And none of this happened overnight. Rather, it was a gradual process where we added insurance contracts one at a time, starting with Medicare, and we billed for services one discipline at a time. We started with occupational therapy and then social work. And although our reimbursement revenue was not very significant during the grant, we created the system for billing and learned the timing and nuances of revenue cycle management to continue this practice in a much more robust way after the grant. Next slide. So we devoted the project period to mastering COPE delivery and building a reimbursement infrastructure, not on maximizing reimbursement. But we learned valuable lessons that prepared us to improve clinician productivity and billing efficiency after the grant. For example, since we span a bi-state area and insurance is regulated at the state level, we learned that coverage for the same code can vary by state, even by the same payer. So during the grant, we identified a core set of CPT codes that we most often use for our clinical services, and we contributed to a billing resource guide that is still available today on the NADRC website at the address listed on the slide. This guide is a great resource for the many different categories of billing codes an organization might consider in the delivery of dementia services. Next slide. We also developed fee-based training models. These include paid contracts to create training videos, provide professional education, and consult on research projects. We deliver our general community education at no cost to attendees, but we established fee structures for continuing education credits for professionals, generating revenue while expanding our reach and helping to improve the adoption of best practices across the continuum of care. Next slide. And philanthropy and community support complete this picture. We've secured senior services tax levy funding, built strong relationships with family foundations, and hosted events that connect donors with the measurable impact of their giving. Philanthropy thrives when stories are compelling and outcomes are clear. And because the ACL grants require extensive evaluation, grantees are left with both compelling stories and hard data to demonstrate impact. And in this way, ACL grants actually fuel philanthropy. Next slide. From this journey, we've learned that sustainability requires multiple pillars. Partnerships open doors and bring credibility. Billing is possible, but requires a significant investment of staff time and resources. And philanthropy succeeds when data and human stories come together. Next steps. So what does this mean for grantees? It means we must consider sustainability from the start, not as an afterthought. Don't even wait for the planning period. Start during your application period, so sustainability activities can be built into the project budget and work plan. Look at ADPI grants as an opportunity to serve your community and an opportunity to build lasting infrastructure at your organization. Use the federal investment to diversify funding streams, cultivate partnerships, and align with priorities at state and national levels. Looking ahead for my organization, we applied for a 2022 ACL grant to align our dementia navigation program with the care ecosystem evidence base. And we are just now wrapping up that project and are about to write our final report. So, thinking ahead about sustainability, our plan for the latest grant is the Medicare Guide pilot model in which we are participants. So maybe I can come back for a webinar at a later date and let you know how that sustainability plan ultimately works out for Memory Care Home Solutions. Next slide. I'd like to acknowledge the many partners who made this work possible. The Washington University Memory Diagnostic Center, the Brown School Evaluation Center, Dr. Lori Gitlin and Dr. Kathy Pearsall, and most of all, our amazing clients and families. We're also grateful to St. Louis University and the Association on Aging with Developmental Disabilities and Perry County Memorial Hospital for their partnership. Next slide. In closing, I return to our guiding vision, empowering families and transforming dementia care, which these grants certainly help us to accomplish. Thank you for joining today. The QR code takes you to our website if you'd like to learn more. And I look forward to your questions.
Great. Thank you so much, Jill. So as you are grabbing that QR code, if you would like it, please also consider adding some questions into the Q&A pod that you see on the webinar platform. We did have some questions come in, so I will get started with those. For both Melissa and Jill, can you respond about how grantees reported for you, Melissa, or how you, Jill, continue to monitor program activity and impact after grant funding ends? And Jill, do you want to start since your mic is ready?
Sure. Will you repeat the question, Sari? I was distracted by all the great questions in Q&A. Remind me what question I'm answering.
Well, I have some questions that came in another method. You're not going to see
this.
How do you continue to monitor program activity and impact after grant funding ends?
So for our organization, this is something we adapted. We didn't use every question in the evaluation instruments that we were using during the grant cycle, but we continue to evaluate program outcomes and monitor for fidelity by streamlining some of the assessments that we use during the grant project period. And just incorporating that into part of our workflow and quarterly quality assurance activities.
Great, thank you. Melissa, do you have any insight into what the grantees said from our survey?
For
In terms of how if they were monitoring program activity impact after grant funding ended.
So we definitely asked if they were still collecting data, and most of the grantees who were still sustaining did report that they were still collecting some form of data on the impact of the programs they were sustaining even after the grant funding ended. Like Jill said, I think many of them kind of tweak that moving forward after the grant period ends. And they do find, like Nevada Senior Services said, kind of that one thing that's most important for them to or to payers or funders, you know, that show impact and kind of convince others to support the program moving forward. But yes, most do still collect some data even after the grant funding ends.
Great, thank you. So Jill, can you talk about the proportion of sustainability funding that comes from philanthropy relative to insurance or private pay?
Sure. So currently at our organization, we have a fairly diverse mix of revenue, with about a quarter of our revenue coming from paid contracts. And much of that is with the state of Missouri, but we have other contracted partners. About a quarter is through grant funding, a quarter through our billing and reimbursement, and a quarter through philanthropy. And I would say we were closer to half of our annual revenue being related to philanthropy prior to embarking on ACL grants. So it's a significant shift for us towards sustainability, that we are now only 25% dependent on philanthropy.
Great, thank you. So I see a lot of questions about the slides in the recording. As a reminder, everyone who is here today will get the slides in the recording. So we will send those out via email, so don't worry about that. Okay, can you talk a little bit, Jill, about the climate for billing for services and what advice or recommendations you might have for organizations that want to explore that option?
Yeah, I mean, I would say we would not have had the capacity to do that work because we did not have the billing infrastructure in place prior to, thinking about this COPE opportunity. So it is certainly something easier to do if you can partner with an organization that is already billing healthcare services, because that would indicate that the infrastructure is in place. We had the help of a billing vendor. We've had the help of credentialing and a contract enrollment vendor. So I mean, we first embarked on doing all of those things ourselves, and it's just such a steep learning curve. And we did start out. We credentialed our organization with two Medicare MACs, the administrative contractors, because our bi-state region is served by two different Medicare contractors. And we credentialed our OTs ourselves. But once we saw how much time that was taking for our staff, we looked for vendors who could take some of that workload off of our plates so that we could concentrate with our staff. Instead of having social workers learn how to credential us with Medicare, we put people to work serving clients and found vendors who could help us with those more technical skills. So when I said we learned a lot of lessons the hard way, I mean, that is really true. And it's a big infrastructure to build. So, I mean, my biggest, it's not easy. There is a ton of regulation with Medicare billing. But for our organization, it was a very strategic decision because it's one way that we can keep programs accessible and affordable to people. So, and we think of dementia as a chronic health condition for which people should have some access to treatment through the health insurance benefits they've paid into most of their lives. So that was a real strategic decision for us, and we're glad we did it, but I would say it's not for everyone. And if you can find partners through people who are already billing or through vendors who can take off some of that workload for you, those would be my recommendations.
Great, thank you. Jill, can you talk a little bit about one, if COPE was provided in any hybrid format or if it was all in person, and then some examples of what the OT does in the COPE intervention?
Absolutely. So when we started out with our project, COVID was not, we didn't know COVID was coming in our future. So we intended to deliver this intervention purely in home. And in fact, there was not an opportunity through Medicare for any telehealth occupational therapy services through Part B billing. So that was not even an option to us when we started. But this project period did span the COVID pandemic. And there were some policy changes, and the CARES Act during that time did allow for occupational therapy services to be delivered and reimbursed via telehealth modality. There was a short period of our project where we did COPE purely telehealth. And we did, in our final project evaluation, look at outcomes, and we found that people who received COPE in a purely virtual way had very similar outcomes to people who received COPE in person. But what we found after the pandemic, and as we sought to sustain the work, is that people prefer in-home occupational therapy sessions for the hands-on learning and really hands-on environmental modification piece of the intervention. So where we have landed, and we don't know that OT telehealth billing will be approved forever, but telehealth coverage has been expanded. So we have landed at kind of a hybrid. We do many of the visits in home, and we do a couple visits, particularly those that might be upsetting to the person living with dementia or triggering, or where we really want to focus on caregiver education around the results of the person living with dementia's functional assessments. We continue to deliver those sessions of COPE in a virtual way. So we landed at a hybrid. It can absolutely be done in a hybrid sort of way. Now that we can be together with other people prefer in-person visits. So that does limit the geographic reach of our in-home occupational therapy services, because we cannot cover our entire state of Missouri by sending occupational therapists to drive everywhere. So we do have a smaller geographic reach for our OT program.
Great, thank you. Melissa, can you talk to if any grantees that participated in the survey identified funding sources to sustain respite services?
Yeah, so, and this is a plug for the report when it comes out as well. So I kind of gave the results at a high level, but we also broke down results by the category of activity, the grant activities, and respite is one of the activities that we looked at specifically. And I'm just looking at the report, and it looks like the most common kind of funding source for sustaining respite was state funding for grantees that were sustaining, and then followed by philanthropy and earmarking existing funds from their original budget for that service. So state funding is the most common funding source.
Great, thank you. So Jill, can you talk a little bit about how you and your team decide which programs or activities should be sustained? If everything's sustained, can you tell us why? If sometimes you have to make a pick or choose decision, what kind of gets you over that hump of making the decision to continue or discontinue a service?
Yeah, I would say the variables that we consider most heavily are one, I mean, outcome. Are we moving the needle? Like, is it aligned with our mission in a way that actually is improving quality of life for the people that we serve? So that's number one. And from a training perspective, where we're serving kind of professionals, even more so than people living with dementia, we also measure impact on, do we change practice attitudes and patterns? Do people plan to care for and serve people living with dementia differently as a result of our education and training? So outcomes are very central to what we can, wish to sustain, but almost as equal to outcomes is experience, as the client experience. Like, everything that we do is from our governing body with our board, for our staff who have lived experience, is really about, do the people that we serve, like, not only do they have measurable outcomes, but do they feel satisfied? Do they feel like they're having a great experience and these programs are meeting their needs? And that the overwhelming feedback, like, our outcomes are good, the satisfaction results are astronomically, overwhelmingly positive. I think we always have over 95%, approval, in that people feel really well served through these programs. And then the other variable is sustainability, is, can we find the right mix of revenue streams to continue the work? So it's a big analysis once we've tried something like this to make sure it meets all of those criteria.
Great, thank you. Melissa, can you talk a little bit about what you hear from grantees, either through the survey or in your work at the National Alzheimer's and Dementia Resource Center, about the types of data or indicators that grantees use for measuring impact that might build on what Jill has just talked about?
Yeah, so we didn't ask that question specifically in the survey. We just asked whether or not they were still collecting data. So I think it would be interesting to kind of dive deeper into that in future publications. But I think, like Jill said, it really is the impact piece that most grantees find are the most important things to continue. Like, if they need to narrow down the number of outcomes that they're measuring, they'll usually go to like quality of life, reduce caregiver burden, those sorts of things. And I also just wanted to mention that we hear a lot about the importance of collecting powerful stories. So outside of like the quantitative data that grantees collect, really making sure that they have stories collected, that they have champions that they can turn to who might have been impacted by the work, who can kind of share about how it has been helpful for them moving forward as well.
Great, thank you. Can you talk a little bit about, Jill, about how you promote the programs that you offer?
Yeah, I think that's one piece of what makes our work unique, is that we have a really robust referral pipeline, but I can't say that we do a ton of marketing, because that is just not something that is in the budget of our nonprofit. So we have found, like, there's no wrong door to being connected to our organization, and referrals can come from many sources, but we have found that healthcare providers who treat a lot of patients who are being diagnosed with dementia. So that's primarily neurology and geriatricians are kind of our largest volume of referral sources. So, we have a couple university academic health systems in our area that really specialize in diagnosing dementia. And that's, of course, those are our biggest referral partners. We also work really closely with other like-missioned community organizations like the Alzheimer's Association and our local area agencies on aging. We have about 3 or 4 AAAs who we work really closely with. So, and through the Dementia Network activities that we did as part of this grant project, it established like quarterly convening. So it opened up communication pipelines that didn't exist before this grant. So as much as, when we started out on this grant, I was a little reluctant about like, do we need to build a dementia network? But it turns out we did need to build a dementia network because that is our communication network for sharing information about our education and trainings and for connecting families who need help to our direct services.
Great, thank you so much. Last question that we want to try and answer is talking a little bit about the services that the Dementia Navigator provides. Can you hit that one, Jill, in like 30 to 45 seconds?
Yes. So, I think the best way to answer that is now we use the care ecosystem protocol. So it's moving families through a comprehensive assessment and helping them like set goals and accomplish things related to medication management, long-term advanced care planning, safety planning for the home, self-care for the caregiver. It's moving people through the care ecosystem curriculum in a really customized way through monthly meetings. And so that we do deliver primarily via telehealth. People can either come into our office for in-person meetings or we meet with them over Zoom.
Great, thank you.
And I will say our clinical staff, then like our occupational therapists and licensed clinical social workers support our navigation team. So it's another role for the clinicians when they aren't doing fee-for-service reimbursement work. They are working as part of an interdisciplinary team to support our navigation clients.
Great, thank you so much. Well, we want to close out today by thanking everyone for joining us for this webinar. I hope that everyone found it as informative as I did, and thank you to Jill and Melissa for sharing their knowledge. Any final closing remarks that either of you want to make before I let everyone know about our next webinar?
Nope, I see questions and people are welcome to email me if a question didn't get answered in our session.
Excellent, thank you.
And nothing for me. I just wanted to say the report will be coming out soon.
Yes, the report will be coming out soon. We will send you the recording of the session and the slides. And we want to remind you that our next webinar will be September 22nd at 1 p.m. Eastern. It is called Caring Through Culture, End-of-Life Dementia Care Through Storytelling. We hope that you can join us. If you did not yet receive the registration information for that webinar and you are interested in attending, please send an email to NADRC-webinars@rti.org and we will get you the information. And if you have any questions, you can email us at that address as well. So thank you everyone for being here and we hope to see you again soon. Take care.